There's only 4 answers here, right? You're going to have 5 answers. But the 5th one is usually going to be some craziness. But yeah, there's no way, no day. That's not the answer. So take a look at this real quick. Give you guys like, I don't know, a couple seconds, 20 seconds or so to take it in. All right, because you got to be able to answer these questions in a minute, right? 60 seconds. Yeah. Not particularly challenging, right? But it's wordy. You got to read through that, think out the information that's pertinent, then look at the question, right? Always look at the question that's being asked. Then look at the answers. It doesn't immediately jump at you, right? Or you can immediately exclude 2 or 3, narrow it down, then you go back to the stem again and say, okay, yep, that's what it is. That's what we're zeroing in on. And then hopefully you're left between 2 answer choices and you pick the right one, right? So we can immediately assume a couple different things, right? So this is telling you you have quadriceps weakness, correct? Patients having difficulty going up and down stairs. This is classic quadriceps weakness, okay? So again, there's more than just a question here. There's a lot of context being given to you too. Because I told you when orthopedic patients present, or we'll call them musculoskeletal, right? When musculoskeletal patients present, then you have to take in the whole history. So maybe they tell you they're having weakness going up and down stairs, right? So you put things in compartments, start to categorize things. That's what your reading sheets are for. Okay, to kind of put things in context, differentiate different diagnoses on your differential diagnosis list, and come up with the most common. So, before we answer the question, let's go through some basic stuff. We have time today, right? Let's do a little test review. A little one, okay? So, patellar reflex involves what nerves? Not nerve root, but what nerves play a role in it? L2 to L4? Is that what you said, sir? Okay. So L2 to L4 is probably the more correct answer. L3 to L4 is not incorrect. But as you go descending, you have more involvement. And with the patellar reflex, it's primarily L4. Does that make sense to you guys? It's kind of like what we talked about with the biceps and the brachioradialis reflexes, because the biceps and brachioradialis are kind of contiguous, correct? The answer is yes. Yes. Okay. I was going to wait for the answer, right? But it's primarily L4, right, and not L5, correct? Okay. Because thank you for answering. Because when you look at a scenario, it's not trying to trick you. It's just trying to tell you what's primarily involved, essentially. Okay, so again, there's a difference between nerve levels, vertebral levels, and where the spinal cord or spinal nerves exit the intervertebral foramen, right? And involvement, because things as they go down, do they become contiguous? Yes, like we just discussed. So they kind of coalesce in some areas, right? So you can have some crossover, basically, is what I'm saying. Okay, where is the sensation here? Medial lower leg. That's primarily L4. So you see how you're supposed to be thinking about these things, right? I'm trying to help you. Okay? It's not just that you're like, oh, I know that the patellar reflex is this. Like I told you guys last week, I think, and I've been saying over and over, you got to put it all together in context. It's not necessarily an absolute when it comes to neurology, unfortunately, because, again, neurology is a complex subject, right? The way your body is designed is very complex, especially when we discuss neurology and neurologic deficits, okay? So, what do we think the answer is? C, L4? Okay. So a couple of distractors here, because Pants loves to get distracted, right? So the distractor there will try to lead you down the path of just acute lower back pain. Back strain, back sprain, whichever one you want to classify it as, right? So that first sentence there, right, if you were just to read that, might you answer it incorrectly? Yes, because you're telling yourself this is non-radicular in nature. Make sense? All right, so don't fall for that. All right? Test question design sometimes is will trip up students that are trying to speed read. Okay, so don't fall for that. Good to go? So we think that L4 is the answer?
Yeah.
Let's find out. L4 is the answer. See? And I've been telling people, again, let's not get big heads or whatever. We had a discussion yesterday with a couple of instructors, actually. This class is pretty sharp, okay? So I'd say that to you guys, sir. You don't even want me to finish my compliment. Okay, go ahead. Go ahead, I'll skip that. Nice socks, by the way. Yeah. Let me put the question back.
Is that enough to use it as
No. So his question was, just saying that one thing is abnormal, is that enough to deduce it's L4? I would say no, because again, there's some crossover, right? So the questions, the way they'll design, that's a really good question. I have to pick on somebody that asked a bad question and just make fun of the generator. But basically, the question is trying to throw you off, right? Because whenever I keep harping on the fact that diminished is not the same thing as absent, correct? There's different grades, okay? So 2+ is normal, right? 2+ reflexes? Okay, so just because it's diminished doesn't mean that that's the primary nerve root that's involved. So it is meant to kind of throw you off again. There are some distractors in here that if you read too quick, you don't read for context, and more importantly, if you don't put together 1 + 1 + 1 and get 3, you get some other number, right, 4 or 5, whatever, you may miss it because you're not putting it all together in context, okay? So let me ask you a question. So if you take that first sentence out, does that change the question? It doesn't. So you look at this question, right, as an astute student, and you tell yourself, I really just have to figure out the motor, the sensation, and the DTRs, put those 3 factors together, come up with the answer, look at the bottom, there it is, answer it and move on. Okay, why do I tell you guys that? When I just took my board review, and again, no test compromises occurring, but when I took my board research, excuse me, not review, the review was brutal, but the research was probably worse. But it's this long question, this long paragraph, right? And then you get to the question, you're like, I don't need any of this information to answer this question. It's like this big lead up, and you're like, oh, this is going to be something. I got to figure this out, I got to get faster about this. Then you get to the question, you're like, I didn't even need any of that. Okay, so if it helps you, right, if it doesn't help you, move on with it. But if it helps you, sometimes read the question that it's asking first, right? Because then you get a context as you're reading the stem itself as to what it's leading towards, and you can start picking things out of the stem, right, of the vignette, and get to it a little bit faster. If that's not helpful, then don't do it. But I'm just telling you, I wasted a lot of time reading. I'm a terrible test taker, by the way, right? I just am. If it's an hour-long test, I'll be done at 58, 59 minutes, right? Because I'm just too critical. I don't know. Something about me, right? I don't want to miss any little detail. I'm trying to be real critical about it. And I don't, you don't need to be that way necessarily. Sometimes you just have to read the question it's asking you, pick out the information you need, and move on with it, okay? Did I answer your question, Captain Daniels? Or do you have another question? No, okay. Did I answer your question, no? Okay, good. You'll tell me later I did. But that's okay. That's okay. This is an evolving conversation, right? So, any questions about this question? Question mark? Okay. Question for you guys. If I were to develop a series of questions like this and attach it at the end
Yes.
and post it, the answer's already yes, okay. then you guys would feel that was helpful, right?
Yes.
Okay. All right. And to answer, I won't pick on anybody, but to answer somebody else's question, I will not just change the patient's age and put the same question on your test. Okay? That's just too easy, all right? So the answer to that question is no. Okay? All right, I will dim the lights now. So. Oops. Or maybe not. Okay. All right, moving on. All right, we don't have much left today, right?
Sir.
Yeah. What do you guys have after me?
Rule.
Farm? Okay.
Farm.
And then what does your day look like? Is it going to be a long day, short day? Short day? Okay, so if I were to finish early, you call your next instructor in, that would benefit you? Okay, couple of rules here, okay? I try to treat you guys as adults. I try to, again, respect your time, right? So if you call the instructor in to start early next go around, cool. But that time can also be used to finish up your assignments if you need be. Because today we're going to talk about spinal listhesis and we're going to talk about Scotty dog and things like that. So that's another way to use your time. All right? Well, you guys will make decisions as adults and your class leader will execute. Okay? Good to go? That's my disclaimer. Metastatic disease. All right, so Mets. So why do we only talk about metastatic disease and not specifically the cancers? Am I a cancer specialist?
No.
No. Are there orthopedists that are? Yes. Right, ortho, right? How many of those in the military currently? I don't know. But at one point, there was only 4, okay? So that's to say there's not a lot of them out there. Usually, again, when you're in a room full of orthopedic surgeons, and you look at around the room, you try to figure out who the smartest guy is, it's usually the ortho guy. Those guys have to be super on point. All right, they're dealing with not only taking out tumors in bones, but recreating bones, recreating joints, right? I saw a scapular reconstruction surgery when I was at Portsmouth. I mean, that is, everybody came for that one, right? This bone tumor had destroyed the scapula, and they had to recreate the scapula itself, and then all those muscular attachments. It's craziness, right? So again, super complicated. So what's my point in saying that? Other than telling you war stories, right? Because we all love those. Is to tell you that when it comes to this kind of stuff, your suspicion or your index to get a referral or to call somebody, reach out and touch someone, right, should be high. If you suspect that a patient has metastatic disease, you need to load the boat, as we say, okay? It may not just be ortho-onc. It may actually be oncology as well. It may be other specialties, okay? So all I really talk about is how metastatic disease, or METS, relates to orthopedics. Good to go? So getting right into it, in bold gold there it says from, F-R-I-M, right? So basically, primary bone tumors, are they very common in orthopedics? No. So if you see a bone tumor or some kind of concern for a mass, or a space-occupying mass or lesion, you need to think to yourself, where did this come from? Okay, so for the purposes of your book, where does your book think it comes from? And for the most part, it is correct. Breast, lung, prostate, colon, thyroid, and kidney. Okay, but that's not to say all cancers, right? If we zero in specifically on prostate, does that metastasize to the spine? Very commonly. Okay, you guys probably already know this, okay? So if you have somebody with lower back pain, and then again, as astute clinicians, you get imaging and you see something in the vertebral column, you should be highly suspicious in a 60-year-old male, okay? Not in a 60-year-old female. That stands to reason, right? Right? So malignant primary bone tumors are rare. Bone tumors are more common than soft tissue, though, if they do occur. Okay? Usually with this stuff, we find it, we call them incidental omas. You get imaging for knee pain, and all of a sudden you see a proximal tibia tumor, right? Is tumor necessarily a bad word? Does that mean it's malignant? No, could be benign, right? But patients with known primary being evaluated for metastatic disease may undergo a complete body scan to see if it's where it is, right? And identify other areas of concern. And when you guys, again, get into hematology oncology, you'll discuss more about those incidents and the relationships there, okay? Neurologic findings in patients with or without a history of primary tumor may be present, okay? So that just because they have a tumor does not, is not to say that they have neurologic symptoms, okay? But remember we talked about if you can't figure out why this patient's having these type of symptoms, are you gonna get an MRI? Yeah, so we talked about that specifically with discitis, right? Sometimes you're like, well, we've done the proper treatment, the fevers are down, what's going on here? Right, you thought it was infection, but it may also be tumor, okay? That's not to say that one caused the other, but maybe that's just, that patient just has bad luck, right? So, pain is a primary sign of cancer in patients who are not aware they had a primary tumor. So usually, again, with, unfortunately, with prostate cancer, a lot of times, you know, you may see a patient and see them and say, the patient tells you, I didn't know I had a metastatic disease. I didn't know I had prostate cancer until I started having back pain, and they did imaging, and then they got the PSA. They did those studies that they do, the people that look at soft, squishy things, right? And they found the cancer. They found the source. So you should always ask yourself with this topic, what is the source? Okay, that's my knowledge I'm imparting upon you. I don't just chalk it up to, well, I'll just send them to ortho, and they'll look at the tumor and they'll figure it out. The short answer is we won't, right? We only deal in the spinal column, some specialties, right? We won't treat the overall systemic stuff, right? So an oncologist is more appropriate for that. Any questions about that? Okay, so concerning symptoms, it's in gold there, pain that prevents sleep. Okay, so a lot of patients say that they have discomfort. Let's say they have a labral tear, something like that. They say they have discomfort when they're laying on that shoulder. Sure, but this is pain, pain, pain. This is pain that wakes them up. This is pain that's pain out of proportion. Okay, they may describe pain with weight-bearing activities, pain with standing, sitting, and again, if it's progressive enough, right, then they can have radicular symptoms and or myelopathy as well. Good to go? Can a tumor, a metastatic bone tumor, cause lumbar stenosis? Yes, and as it continues to grow, right, or progress, I should say, right, it will then start to invade that canal even more, and it will cause compression of the spinal cord. So you may find it because the patient just presents for sudden onset of myelopathy, or sudden onset, of radiculopathy that progresses to myelopathy. Good to go? We're putting it all together, right? All right, so complete neurologic assessment, again, is paramount, right? You're never going to not do one. In the case of prostate cancer, again, patients will commonly have metastasis, and you'll be able to percuss that vertebrae, right? And be like, there's point tenderness there, there's focal tenderness there. Then you get your imaging, and that's where the tumor is, right? If they're actually on the posterior aspect and not the anterior aspect, then you may actually be able to feel them, okay? That's what that's getting at there. Kyphosis can develop if vertebral collapse occurs. So basically what that's saying is if it's an invasive bone tumor that's destroying, right, lysis, right? It's destroying the components of the vertebral column, whether it's anterior or posterior, it can cause a collapse, right? If you cause a collapse, then you can have kyphosis. And again, here we're talking about hyperkyphosis, correct? All right, I really hate that term because it doesn't really describe it well, but we are where we are. So if it gets bad enough and it's progressive enough, obviously you can have quadriplegia and paraplegia due to pathologic fractures. And again, that goes to that concept that things are going to start collapsing, things are going to start breaking down, and you don't have structural integrity anymore. So once you have instability, then it can cause collapse. Okay? So anytime you have a concern for any kind of back pain out of character, we talked about this already, right? You guys are going to get radiographs, correct? Okay, good. The answer is yes. So you're looking for this pedicle, loss of the pedicle. And what's that called? Did you guys already discuss this in other classes? No? Okay. This is new for you. Okay, so the winking out sign is important to know. Important to know, okay? Because that may be something you see on a board question, pants, right? And they'll give you the winking out sign. They'll say there's a loss of the pedicle on an AP image, okay? And this is what they're describing, okay? Do you see the winking out? No. I never do either. I don't really know what they're talking about. But at the same time, I know what it looks like, right? I don't know about the owl, but I know what it looks like, right? So on that axial cut there, you can see that area where it's destroyed, right? There's bony destruction, okay? So that's what they're getting at there. Then you have vertebral collapse, okay? So you have a collapse of vertebral height on the lateral view, okay? This titanium 99M bone scan, special kind of bone scan, right? You guys talked about that in radiology? Okay, so you guys know that's a certain type, right? And it's a bench screening study to identify widespread Mets disease. And that's what I was talking about earlier, is that, you got to, if you see some tumor in one place, you don't just say, well, we're just going to treat that. You got to start searching, okay? Start digging, start investigating, okay? Winking out sign. You see how I added this red circle with the blurry, to kind of accentuate? That's not normal. Okay, so you see an area of decreased bone density and what appears to be destruction, right? Then you get the MRI and you see your winking out sign. Are we good with that? Okay, take a look at that, study it, okay? Because that's something that, again, it's in red, right? That's a bad finding. You should know what that looks like. Non-operative, treat the tumor in primary cancer. So if you're talking about non-operative, you're talking about chemotherapy, right? You're talking about hormone therapy, you're talking about radiation therapy. Operative, obviously, if it gets to a point where it's been staged, right? You guys will get more into that in oncology, but it's been classified and staged, then you may be more aggressive about operative intervention, okay? But some clear indicators are going to be pain and neurologic deficit. So if you go in there and you're taking a tumor out or an area of bony destruction and try to get all the components of that tumor out, do you think that you're going to be left with a void? Yes. So therefore you have instability, right? So then you need to do stabilization as well. And just because you do the Lord's work in surgery, right, doesn't mean that you can't also need to do all those therapies that we talked about a second ago. So again, this could be a multidisciplinary approach, depending on what tumor we're talking about and what kind of widespread systemic disease is present. Okay, good to go? All right, neurologic deterioration persists in some patients as an adverse outcome. So just because you go in there and you do, again, the Lord's work, do the high-five surgery, doesn't mean that you won't have persistent neurologic symptoms, okay? Surgical wound complications due to radiation therapy and oral. So this picture here is a wound that just refuses to close, okay? So you go in there, you do the surgery. The patient's also undergoing radiation versus chemotherapy or both, right? Do you think they're going to have some issues with wound healing? It's possible, right? They're immune compromised at that point, correct? So do you think they could have a concern for infection potentially?
Yeah.
Yes, right? So that's the thing. I don't know why there was a date on that picture, but 2018 was a bad day for that patient, right? 6/2/2018. So it's important to understand that just because the patient has surgery, you may, as a PCM, see them in a follow-up for, let's say, their referral for an eye appointment or something. I don't know, pick something, right? And then you look at that, they say, this wound just doesn't seem to be closing. And you say, well, show it to me real quick. Should you have a concern if you see something like this, right? You're not going to go digging around there, right? You're not going to stick a CTA in that necessarily, because especially if it goes down to the spine, right? So you would call the surgeon, right? Well, we're calling surgeons. Everybody knows how surgeons are mean, right? They're bad people. Us surgical people, we love to eat people for breakfast. We love to be mean. Quite the opposite. I think you'll find that a lot of the orthopedic oncologists are people that actually like to talk to people, because these patients share their lives with us, right? When I was in orthopedic oncology rotation in my fellowship, we spent a lot of time talking about the patient, but not just their disease, their imaging, right? Their treatment, but also them as people, because you really get to know these people, okay? So please, please, please don't be afraid to reach out to the orthopedic oncologist if you have a concern. Good to go? Okay, if you're an overseas location or you're one of those PCMs who's clearing people to go to overseas location, if they're undergoing therapy that has, and the treating surgeon has not weighed in, and you clear them to get forward deployed or PCS overseas, you're not doing the patient a service. Okay, make sure you get weigh in from their treating oncologist, because if they come to Misawa Air Base or Okinawa, Japan, we don't have those services there. So to force that patient to have to go back to the States to, for follow-up, it's just unfair, right? But I want to go to Japan. Yeah, we all do, right? So, but maybe this isn't the right time, okay? Referral decisions, all patients with prior malignancies. If they have a history of cancer and now you have another concern for cancer, you refer, okay? It's just that simple. If they have any kind of spinal symptoms or intractable pain, meaning pain on a proportion, pain that doesn't get better with conservative care, you refer. If, again, like I said, if you don't know the source, you need to get oncology involved. I would say you need to get oncology involved regardless, but definitely in this case. Any questions about metastatic disease? Pretty straightforward, right? As far as orthopedics. But when you get into oncology and you start talking about all these other very specific cancers, right? Brain tumors, kidney tumors, things like that, okay? But for the purposes of orthopedics, keep it simple. I will only test you on the material that's been presented, okay? All right, scoliosis. So getting back to kyphosis and lordosis, when we discuss kyphosis, lordosis, those are in the from the lateral view, correct? Okay. And so therefore it's sagittal, correct? Or lateral x-rays. When we're talking about scoliosis, right, then you kind of incorporate a few different things. So curvature is not just in one plane, right? So very commonly we like to think of scoliosis as being that. You see the curve back there. And you say, well, I see it in this plane, so that's scoliosis. Can you also have rotary involvement? Yeah, so it's multiple planes. So you get your brain has to go into beautiful mind mode, right? And kind of like rotate the patient around and think to yourself, what does this look like in multiple planes? So in kids, it tends to be idiopathic, meaning congenital, correct? They're born that way, okay? In adults, it tends to be degenerative, all right? Because wear and tear. Again, osteoarthritis is a progressive disease, correct? It's not something that they're born with. That's the difference. In this case, Cobb angle, we talked about that yesterday. How I'm going to make sure that I ask you about 35 questions about measuring Cobb angles, right? But in this case, what's your number? 10, right? And so that's when you start saying it's scoliosis. That doesn't mean that is a referral necessarily, but that's when you start classifying as scoliosis, okay? Adolescent idiopathic scoliosis, 1-to-1 for curves less than 20 degrees, meaning male, females, incidence rate is the same. Girls are more likely to have curvature though greater than 30 degrees, okay? So what that means is even though the incidence is about equal, that in females, they can be more significant and progress more significantly to the point where they need surgical consideration. Any questions about this slide? Okay. Clinical symptoms, pain at the area of deformity. Obviously, if they have an abnormal curvature, right, is that putting abnormal forces through the spinal column? Yes, it's redistributing those forces as well to surrounding structures, therefore they can have muscular pain as well. Make sense? Okay. Progressive spinal deformity, I feel like I'm getting shorter, or I feel like my daughter's getting shorter, right? Hump back, right? It's not like something growing on their back. It's because of the curvature, okay? So that's different. It's not a tumor, okay? Leaning to one side. You guys see that red line down the middle? Yeah? Do we have any plumbers in here? Nobody's a plumber? Okay. I'm a junior plumber. I got a new house. But, so that's called a plumb line. It's just a straight line down the center of the spinal column. So again, if you were to draw an imaginary line, right, after you tell your patient to stand up, take your shirt off, and you're standing behind them at an appropriate distance, please. That's a joke. But you're looking at that line that you draw in your mind, and you're thinking to yourself, they're listing to one side, or the curvatures to one side. And then the hump is really going to be something that you're going to have to either look from the side, if it's that pronounced, right? Or you're going to have them bend forward, correct? Okay? So you guys remember when you went to MEPS and that old man, that old doc, told everybody to stand up in a line, and then went behind everybody and said, all right, everybody bend over, and he walked up and he ran his fingers up your spinous processes. Okay, that's what he was looking for. He was looking for scoliosis. He was looking for abnormal curvature. Okay, I know his breath stank like coffee, and you were wondering to yourself, I wonder if this guy actually sees patients anymore. But that's what they're there. That's what they were checking for. Okay, so if that curvature gets significant enough, we already discussed this with kyphosis as well, or hyperkyphosis. It can cause breathing issues, right? Think about it. Right, cause breathing issues, and it can also cause neurologic deficits, obviously, but with more severe thoracic curves, they can actually have respiratory concerns as well, okay? And that's rarely evident in degenerative scoliosis, okay? So again, this could be something where it's idiopathic juvenile scoliosis, and as it progresses, as the patient gets older, and that curvature accentuates, then they start saying, they're having some respiratory concerns, okay? So a good history is important, okay? Any questions about the plumb line? Okay. Physical exam, there it is. They're leaning forward, and you see how that curvature is accentuated, okay? And then now on the right side there, right? Even though they're standing like this, you can see the curvature there. But on the right side, when they bend over, you see that hump there, okay? So what do you think you expect to see on radiographs, right? You expect to see the accentuation to that side. So the hump will be present. Let me say this slowly. The hump will be present with forward flexion, not necessarily with them just standing, unless it's significantly pronounced. But don't let that confuse you, okay? Do you have a question, sir?
Yes, sir. So would her spine be bending to the left?
So that's a good question. So remember we talked about multiple planes? So if you have enough rotation, right? Think about this. So his question was, let me tell the rest of the class. So his question was, would the spine be curving to the left or the right? Okay? From her standing like there, it looks like it's curving to the right. Okay, but we did discuss how it's in multiple planes, correct? Right? So it may be multifactorial, meaning you may have curvature that's rotary as well. So when you get your radiographs, you're like, wow, it didn't look that bad on exam. But then you get those Cobb angle measurements and you realize it's not only going to the right, but it's at one level, but it's going to the left at another level, and it's going forward as well. Anterior, okay, not forward, anterior. Make sense? So it's not that simple. You can't just say it's one plane. That's why I'm telling you guys, you have to start thinking about things like if you were to do a 3D image of this patient, after you look at the radiographs, because you're like, huh, that's why this looked like that way on physical exam. Make sense? I've seen some bad scoliosis of people trying to join the military. I was a MEPS commander in Guam, right? I was the HMFIC of military entrance for the Pacific Rim, okay? Dude walks in, takes his shirt off, I'm like, disqualified, right? But it's not that simple, right? You gotta get the radiographs, you gotta do that test, you gotta do all that. I gave him a chance. I said, go see a doc, see if you can get cleared, right? Or God forbid, get surgery. Some people do it, believe it or not. Because the, DOD, I won't list the instructions, but basically it states that if you have curvature over a certain amount, you are disqualified, okay? So it's not my thing, right? I'm looking for those measurements on that radiographic report and just saying, hey, based on your curvature in this plane, that plane, you're disqualified. You know, then you send it to the service and say, you want old Hickabog humpback in the Army? Because if you do, clear him, right? But he's disqualified based on the DODI instructions, okay? That was funny, right? So, yeah, so anyways, so you see what I'm getting at, right? That's probably the best example. Thank you for leading into my story. I'm trying to keep you guys entertained, but again, if it's multiple planes, you may see significant curvature, right? And can it be progressive? 100%, right? Juvenile idiopathic scoliosis is something you're going to follow out. You may see an accentuation, or you may see a correction, okay? Okay, any questions about the hump and when you would see the hump? Okay, because when you had, yes, ma'am? We'll talk about that. Yeah, yes, I appreciate your enthusiasm. Wait for it. Okay. All right, so here we go. All right, so if we're talking about imaging and all those measurements and those angles, okay, so we're talking about a PA and lateral weight bearing of the entire weight-bearing spine, okay? So if this x-ray is taken of the patient laying down, useless, okay? The patient has to be standing, and it has to be an entire span of the spine, okay? And again, there's that 10 degrees, right? So then if you do have a child that you're concerned about it, Captain Carabiner, right? I said it right. I keep wanting to say Carabiner, but then you would get an MRI, right? And so why would you get an MRI, right? Abnormal physical exam, okay? Abnormal x-rays. We won't get too much into why left and right-sided curvature is worse or better, because really, is anything good? No, you're going to have some degree of pain with certain degrees of scoliosis regardless, right? But which side's your heart on? Okay, so do you think if you list to the left, okay, that could put more pressure on certain important anatomy in the kill box? Yes. Everybody knows what I mean by the kill box, right? The chest, the cardiothoracic. Yeah. So, okay, so it could cause more compromise. Okay. All right. Good to go. Excessive kyphosis, we already talked about that, why that's bad. Widening of the spinal cord canal, widening of the spinal canal. Okay, just because it widens doesn't mean you get more clearance. It just means that you have now a distorted anatomy, that you can have actually compression in different areas. You know, would it more predispose them to have an intervertebral foramen impingement? Yes, potentially. Erosions on the vertebrae, if you see that, right, then you're gonna refer that. Rib abnormalities, this leads me to talk about a topic that I'm going to talk about real quick. But basically with rib abnormalities, does orthopedics treat rib injuries? The answer is no. You can call me, that's fine. Call me and tell me you have your costochondritis, right? Your person that has rib pain, all these things. You can call me and tell me you have multiple rib fractures. I will say that's great, thank you. I appreciate that. You need to call a cardiothoracic surgeon. Because just because it's a bone, do we operate in the kill box? No, right? You start operating around soft, squishy things, lungs, things like that, that's not ortho. Do some orthopedists do it? Sure. I don't work with those guys. Because usually that means that they're doing all kinds of stuff that maybe I'm not too keen on because I went into orthopedics for a reason, okay? Good to go? So if you see rib abnormalities especially, don't be surprised if you get cardiothoracic involved as well, or if we do, okay? Because we'll treat the scoliosis, correct? But then maybe we need to consult a cardiothoracic surgeon, okay? All right, get a little faster. So non-operative, if it's asymptomatic observation. So this gets to the point, Captain Carbine. Okay, with kids, usually grandma or the parents are gonna bring them in, right? And they're gonna say, I'm just concerned they just look weird. So I can't fix that. I agree, they do look weird. Yeah, but no, I'm joking. But you basically tell them, say, well, a lot of times they'll outgrow it. Okay, so again, like I told you guys before, as they continue to develop, musculature continues to develop, right? And they get muscle tone, things will self-correct. Okay, so a lot of times, unless it's significant, right, you will tell the patient that, hey, For the most part, they're asymptomatic, except maybe with certain activities, okay? Or they're just completely asymptomatic, so we're just gonna watch it. That's what we call watchful waiting, okay? And you're gonna follow them out, okay? If they're skeletally immature, what will you do? If you do decide to treat, you can do that bracing, okay? And that's 25 to 45 degrees of curvature. You think we're getting towards that 50 degrees that we talked about where surgery is indicated? Yes, okay? So again, we're talking about skeletally immature. We're talking about open growth plates, okay? They're continuing to grow, okay? So it's really gonna depend on when the patient presents as well, okay? So skeletally mature though, really at that point, does bracing do any good? No, you'll still see providers that do it though, okay? You'll still see that out there. But again, skeletally mature means you're doing more of the conservative stuff, okay? So you're doing the NSAIDs, RICE, activity modification, PT. Swimming is really good, right? Low impact. You use a lot of body different muscle groups. Okay, that's what I meant to say. Okay, operative, right? Skeletally immature, curves greater than 45 degrees. Okay, so skeletally immature means open growth plates. Okay, because do we want to correct those things before the growth plates close? Potentially, yes. Okay, that way that they stabilize into adulthood. Okay, if they're skeletally mature, then absolutely, again, the indication is 50 to 60 degrees. Okay, now this is a big surgery. There's a lot of instrumentation. I told you guys my woes about the first time I did a spine case, 8-hour case. Right, it's only supposed to be. They told me, oh, they could be in and out, no problem. All right, so this is a big surgery. So again, these curvatures have to be significant before you decide to refer them, because if they're not, the patient's coming with a false sense of we're going to fix them. The only way we can fix that is with surgery, right? So if they're not ready for surgery, don't send them to me. That's what I'm saying, right? Unless you've decided you discuss it with the patient and that they have further concerns that you feel that only I can answer, that's reasonable, okay? I think I'm a reasonable person, okay? Good to go? All right, look at that curvature. Is that going to fix itself? Do those growth plates look closed? Yes, okay? But even if you treat them, you might still have some adverse outcomes of treatment, as your book calls it, okay? They can still have neurologic compromise, they can still have pain, okay? They can still have a concern for infection. The fusions that you do, just because you put all this hardware in there, does it necessarily take? No, it doesn't heal in like you want to sometimes, right? And you have to do what's called revision surgery in some cases, okay? So it's not a slam dunk, all right? Post-op complications are higher in adults. That's just the incidence rate, okay? That's all that's saying. Does that look like significant hardware there? Yeah, like I said, I was involved in that case, first one. Not an adult, but a kid, and man, we were there forever. So I think that case is still going. So, but when you're talking about referral decisions, though, keep it simple, right? You've been watching it for a while, but now they start developing neurologic deterioration, refer them, okay? Progressive pain, okay, it's something you can't manage, right? You refer them, okay? Progression of deformity, again, that's kind of the whole point, that's why you're watching them, right? If they have comorbid neuromuscular disease, have you guys talked about Ehlers-Danlos syndrome or Marfan syndrome or any of that stuff yet? Okay, so you understand that there are other things, right, that predispose certain patients to having muscle tendon issues, right, because it's due to development, right? And so if they have those conditions, then you refer them. Absolutely, if a patient's having trouble breathing, that's kind of important, right? So again, you've been watching this patient, but now they're starting to have progression to respiratory dysfunction, then you refer them, okay? Spondylolisthesis, degenerative, all right? Let's go ahead and take a break now, and we'll come back. Whenever you guys are back, we'll start.
They didn't disqualify you.
No, I guess it's not as bad. But I do have one older one. My husband noticed it as
You have a look on your face.
But yours is a little up, not down, it's lumber.
No. I don't. I never.
I thought you said you showed us one time, you said it was more up here.
No, but you can see some like right here. I know one of them. No, it's look on this one, I look like this. Cancer. Yeah.
But you're not in Texas.
Wait, that's like on island.
That's not.
I was like, I don't need any. They're comfy though.
Yeah, what is that? Is it's like
Yes, that makes my point. That's totally different.
I literally wrote on this. But I still sort of like where you would see it. Yeah, basically it's sort of like it's right there. It's like 2000. It's like a club.
Yeah, she's changing this like. That went from like cool to like only one I like kindergarten ABC song.
That's what I underlabeled. And when it was labeled, I like threw the arrows. There's just like arrows that just
I love
She's so happy. Because it's Thursday.
Full of energy.
As you can see, this line
Typically, you want to see. It's not bad.
Your paycheck go up. Your paycheck go up.
Like a big no. Okay. That was like the. They are. Ask anyone who's alive in that time now.
I was. Thank you.
You're all number one.
No.
With our brother.
And see, they're really like that. It doesn't say anything related to that. Doesn't it sound funny?
The one with Greg is just a C4. Just do it.
Send everything to her. And then she turned around and it's like, okay, here's it. I'll put all this stuff. You just said you can't do that yourself.
Yeah, but that was like.
So it's your job to do.
Bad Bunny used to be good. I know, so like I listen to the same song like you played this song like 3,000 times. So excited. But that's what
So it's a big hospital there. He gave us access to I mean, good for
Yeah, it's like this. That's like saying, have you ever seen a gorilla stretch? No, but gorillas can pick up 5,000 pounds.
Right.
I've never picked up 5,000 pounds in my life.
Clog myself up some more. I'm going to CS1 today.
Hopefully you don't get the wine guy you said.
This is all I have though. I have to go find the MF4.
For it's oh, the Norwegian Foot March. Nice.
You're gonna read this.
In a different language.
This one's in French.
Let me see that.
Did you just do it once? Just do it once.
Yeah, the bronze.
Yeah. Yeah, it was on
General of the Brigade of the Sebastian Valette.
It was on a long-term like
For the
recovery
engagement
from a
and efficiency.
injury, and then we first started. They were doing this week. You want to do it? No, I said no, but my soldiers you want to go and watch.
For the engagement and the efficiency of the actions of the task force saver. Now this Using
So,
Duval.
All you ask
My whole brain.
you don't like wear it. You don't like wear it that right. It's not even. It's hair ribbon. It's like that. Well, ribbon is
French flag.
stop. Well, shoot, I had to get mine at.
Norwegian? No, that French is different.
Oh, it's different. Oh, I thought it was like Norwegian's not anything. You don't wear it. Not even the pin.
You can wear the pin in the same spot as where the Gatsby is.
Oh, but you can only wear one.
Yeah, you can only wear the Gatsby. Like, I put the Gatsby on there, right?
Yeah, the little pin is like this big.
I actually think I have that in here.
Well, that's the thing is like if you also put the gappy on, like if you put the gappy on, you don't have to put the so you never have to change it. It's like when you bounce around.
Yeah. But do you wear the uniform? If you were in the unit when that award was awarded, you know what I mean? It's like a historic award. If you were in it when it got awarded, you wear that one. You wear that one. Yeah, I have it, but it's still pinned into my little frame.
I don't know where mine is.
Yeah, if you get an award, if you get a unit award while you're on deployment, you wear that one award and your deployment. If you not deployed,
Yeah.
then you wear the historic.
Oh, cool. What was it for? What did you have?
One of the French guys died, so we took their picture.
Gotcha.
Yeah. Not a fun one to get. They got an ambush.
No. Oh, the little green on the sides.
There's a French soft team on foot patrol. They got ambushed. They left like they leave. We got out there. We watched them on it's called the SR. It's going crazy.
How long have you been in these?
At night, they're about
You don't get it.
It's already a fart spray. Next time that happens, we'll spray it.
You guys ready? Always ready. All right. So, just a quick side note. I don't hate chiropractors, right? I don't. But the point I'm trying to make with that story, with those little stories, I told you I love Larry. Larry's a good dude. He's doing something right because he's driving a real nice car. Right? He probably can't afford it, but he's driving. So, but the big thing about that slide there, and you hear about it in my test review too, is don't confuse cervical traction with cervical manipulation. Cervical traction can be okay as long as it's applied appropriately. Cervical manipulation is a no-go, no-no. Okay? So if you get a test question about that sometime soon, right? Whether it be pants, phase 2, whatever. Next, don't say that. No test compromise. But maybe next Friday. Then the answer is not that, right? Except when it's no. That's why I qualify that. All right, so, and then the other thing is, when you're talking, today we kind of, I mentioned it, right, but I think this all the time. When we're talking about imaging, right, when you're looking at the lateral view, believe it or not, with the lateral view, and especially if you take the lateral view of a spine, for example, right, say the lumbar spine, and the oblique view, right, you can recreate in your mind, once you get to a certain point in your career, what is going on, okay? And that's what you're trying to do when you're looking at spondylolisthesis. You're trying to recreate those things in your mind and try to get a sense of whether or not you have anterior-posterior translation, okay? So how many x-rays or MRIs or CTs or whatever are you going to have to look at before you get that skill set? Every single freaking one that you get your hands on. And once you look at about 100, that's a good starting point. Okay, because then maybe you feel confident. Okay? So when you guys get out there in phase 2, look at imaging. Okay? Before you go see a patient, okay? Before you present a patient, if you have access to the PAC system or a medic can pull it up for you, right? Look at it. Right? That way you have a sense and you don't put the proverbial other foot in your mouth. Okay? Because you already put the first one in there, right? Just kidding. All right, spondylolisthesis. So just in general, spondylolisthesis, what is it? Okay, we've been dancing around this subject for a bit. So spondylolisthesis, excuse me, it is slippage. That's the way you should think about it. Okay, spondylolysis is fracture, correct? Okay, you guys know that slide I gave you. Okay, so slippage, listhesis, cause could be either congenital, they came out the chute like that, or a stress fracture or a progressive fracture, basically, due to stress forces. Okay, make sense? Okay, so when we talk about spondylolisthesis, and now we talk about isthmic. Okay, again, isthmic is something you're going to see more in younger patients. Okay, but having said that, do you think if it was undiagnosed, that you may see it in an older patient that's always had it? Yes, but by definition, isthmic is what you're talking about here, okay? So when you're talking about that, again, and you're talking about a defect, or just say a fracture, then you get to the lysis, spondylolysis, okay? And it's a defect of which area that you can see better on the oblique view? This is an important concept. Pars interarticularis, right? It's on the screen. Okay? The pars interarticularis. And you guys all know what that is in relation to the vertebral column, right?
Yeah.
All experts. After that lecture I gave, you guys are experts. Okay? And that was supposedly a review, right? So you guys You guys see the area where the yellow arrow is? Okay? That is the pars interarticularis. So then you have a spondylolysis, right, as the image progresses, so you have a defect, and then progressively you have spondylolisthesis. Now that articulation point has been taken away, if you think of it in those terms, then you have slippage, and that could be anterior slippage if it's in the lumbar region, which is most common at which level? L5S1, right? Okay. So when you guys are studying this weekend, right, into the wee hours of the morning, okay, drinking your cocoa or whatever, spiked, make sure that when we talked about those common levels for other conditions, you don't get those twisted, okay? Confused, right? My son says twisted. Don't get it twisted, Dad. So in young kids, right, when are they going to present with this kind of pain? They're going to say that they have sports participation. If you put it in a category, that's it. So let me help you, okay? I always try to help you guys. Hands question, right? Adolescent child presents after football practice saying that they've been having ongoing pain, right? X-rays were taken, okay? And there's a pars interarticularis defect. What are you automatically going to jump to in your mind? Spondylolisthesis, okay? Isthmic, correct? Okay, so hopefully you got there. And here that red circle, right, that red focal point there, it gets to what that looks like as far as relevant anatomy that we discussed, it seems like a long time ago now, okay? Here you go. Clinical symptoms, significant back pain that radiates past the knees and worsens with standing. Remember I told you, when you ask the patient, you have back pain, okay, great. Can you describe it more to me? Does it go down the anterior, posterior aspect? Does it go down the lateral aspect of your leg? Does it go to the knee, or does it go below the knee? Does this go past the knees? The answer is yes, okay? All right, I'm losing people. So one thing is particular for whatever reason, right? When the textbooks and when Pants thinks about spondylolisthesis is that they have hamstring tightness. Okay. So do you think that have you guys learned any tests yet to check for hamstring tightness? No? Not in clin skill? Okay. If you guys remind me during lab, as a side note, I'll show you some of those tests, okay? Myself and Colonel Sylvester. Are they testable? No. But how are you going to check for it if you don't know how to do it? Right? Does that make sense? Okay. All right. So slippage can result in neurologic changes. That makes sense to you guys by now, right? Okay. So adverse outcomes disease, you do nothing about it, progressive disability. Okay, like I said, bless you. Okay. Just gonna say thank you. So it can lead obviously to chronic back pain. It can lead to paralysis if it's bad enough, right? And can it lead to chronic Quina syndrome? Yes. Okay, it can. Remember that was on that list that we talked about chronic Quina. Now is that common? No. But let's say if they have spondylolisthesis and then they undergo trauma, they already have an unstable spinal column, right, at the pars interarticularis, so it can predispose them to developing chronic Quina? Yes. So you can think of it as like a risk factor, for example. Okay? So ismic, so remember we talked about that normal lordosis is there, right? It should be correctable, right? Right? That's what you're hoping for, right? So diminished lumbar lordosis and flattening of the buttocks, as Forrest Gump would say, right? So mild flexion of the hips and knees. So if you have tight hamstrings, do you think that things are going to be stretched out anymore? No, they're going to be contracted. So that's where you get that flexion of the hips and knees, right? Range of motion, the tight hamstrings limits the forward bend, okay? So the forward bend that they do may be abnormal, okay? So when we talk about forward bend and extension, we know the difference, right? There's normal ranges, okay? So these are numbers that are not just arbitrary. They are established normal ranges, okay? Straight leg raise, you'll see decreased leg height, okay? These are things, again, as you practice and as you go through phase 2, hopefully you start looking at people. Again, you have them stand up, you stand behind them at an appropriate distance, okay? And you make sure that they have their shirt off, and you're watching them do these procedures, and you're watching their overall alignment, okay? Are neurologic deficits common, though? No, not in ISMIC, okay? And we'll differentiate that when we talk about degenerative. Okay? Significant slip equals step off. So do you think, you remember how we're running our fingers down the spinous processes, right? Do you think if there's significant anterior slippage that then you could fall into a certain space because that that vertebrae is now translated anteriorly? Yes. So that's what you may feel. So as you're running your fingers down the spinous processes, you may feel a depression or a dip in that area, and that's where that anterior slippage has occurred. Does that make sense to everybody? So the patient's laying in the prone position, so on their six-pack, if they have one, right, on their stomach, okay, not their two-pack, which is their buttocks, right? And you're running your finger down their spinous process, and whoop, you fall into a space. That's anterior translation. Make sense? If it's more prominent, it's posterior translation. Make sense? Okay. You'll never forget it now. So isthmic spondylolisthesis typically occurs, patient is 5 to 7 years old. Okay, that's if it presents. Right? So again, they're saying if the patient presents at that age group, that's the age group they're going to present. Right? Good to go? And did I find people with spondylolisthesis that were maybe just barely 18 years old, no real facial hair, all that stuff, and then I ran my fingers down and I'm like, oh, I got a depression here. I gotta get some imaging. And then you're like, hey, did you ever have back pain? Oh, all the time, doc. All the time. You know, I had to stop playing football because of it. That's the history, right? We kind of talked about that. Okay? Imaging, you're gonna get the oblique view. You're gonna see the Scotty dog defect. Now, you guys are now experts at the Scotty dog defect. You can pick it up any X-ray I give you, right?
Correct.
The answer is no in this case, apparently. So. But the answer is a Scotty dog defect. The actual defect is a decapitation, right? And then the slippage. That's what we're talking about here. Okay. So now, hopefully, you know, again, I didn't make you guys turn it in. If you turned it in already, I haven't looked. More power to you. If you want to take it back, work on it some more, that's fine. The whole purpose is for you guys for this to be valuable for you to study with, okay? So there'll be some more images here coming up. But a single photon emission CT, so SPECT, right, is on the immature patients if the radiographs are normal. So if you're highly suspecting it, you got to get a more specialized study. That's a study you do. Okay. But what is the only thing that's bold gold on this page? Scotty dog. Okay. Am I going to give you an image on your test that will say, I want you to label the Scotty dog?
The answer is yes.
The answer is no. Okay. But why do I think? Because like I said, how many x-rays do you think reasonably, because I have, again, I've been a preceptor for almost 2 decades. I always have students say, how many x-rays do you think I need to look at before I just see it? About 100. Okay? So you guys have probably looked at, some of you looked at 0. I'm joking. But maybe you looked at 3 or 4, right? Do you think you're an expert? You're not even approaching that yet. Okay? Right, makes sense? So that's not fair to you. What is fair to you, though, is to understand the pathology and to understand the process. Okay? So if you're given that it's present, then you need to tell me what's up. Okay? Make sense? There it is. Now you see the Scotty dog?
Scotty dog.
Right? So, right? Collar on this superior, right? Or more proximal vertebrae. No collar on the more distal vertebrae. Same thing on this side, right? You see the collar here? Doggy got a collar. This doggy has no collar. Okay? So if you were just to look at this image on the left here and on here, right? Can you pick it out already?
Yeah.
Maybe. Okay? So when you have the PAC system, and I was just talking to a student about this, when you get into the actual imaging system, you will realize that there are different tools in there, right? They can sharpen and dull an image, right? So more contrast, less contrast, and also invert an image. There's all kinds of stuff. So we do tricks, right? To make sure that we sharpen the contrast and we actually see those colors a little bit better, right? So again, it's not just, remember the days of floppy radiographs, right? Right? Then it's more challenging. But now with technology, you can actually use certain tools to sharpen those pars interarticularis and see them a little bit better. Yes, sir.
Sir, does that fraction need to be bilateral for the spondylolisthesis to occur, or is it can be unilateral?
I've never been asked that question before, okay? But by definition, in order to have a high degree of slippage, so his question was, is it, do both pars interarticularis have to be involved for it to be spondylolisthesis? This is a good question. This is actually a really good question. This is a really good question. Because then you'll tell me if you know the difference between spondylolysis and spondylolisthesis. So in order to have anterior translation, do both pars interarticularis need to be involved? So spondylolysis can be present on the left side, right? Not present on the right side, and you have no slippage. Does that concept make sense? But if you have spondylolysis on both sides, then you have an unstable vertebral column, and therefore you have forward slippage. I love this question. I love it. Enough to put it on a test. Yes, no. But it gets me, again, this is why I like this class. Because these type of questions makes me understand that you're not just like, oh, it's in bold gold, I'm just going to memorize that. Right? That may serve you while you're here. But when you're out there rotating and you ask me that question, right, now it's fair game for us to have discussion. When you get to phase 2, the assumption is you know that concept. So that lets me know where you're at as far as not just you, but everybody in your thought process. Do you truly understand this pathology? Right? Because does that relate to the patient's clinical picture and why they're having certain symptomology? Pause. Yes. Right? If you don't have slippage, will you have neurologic deficits? Maybe not. But once they develop slippage, they will. Okay? At some point. Okay? And so this here, if you look at red, that's all the particular areas that are of concern. So again, this is just one defect, right, of the pars interarticularis. Can you have defects in other areas? Yes. That's why it's more complicated than just this. Okay? But for the most part, like I said, the Scotty dog is what you need to know. Non-operative, again, we get back to that bracing, right? There is a picture of the brace. That looks a little bit different than the one before, right? So I forgot this was in here. So this is a picture of the brace. So this is something that if they're skeletonally mature, you can do this bracing. The opinions will differ. Your book says rigid bracing is indicated for skeletonally mature for 3 to 4 months. Okay? Is that going to fix spinal listhesis? Not necessarily, right? But it gives them support. It offloads, right? We talked about that axial load. So it offloads and it prevents anterior posterior translation. Maybe with some concomitant, right, at the same time. Physical therapy, strengthen up muscle groups, they have less symptomology. Do we treat asymptomatic patients that we just find spinal listhesis on incidental x-rays?
Sure.
No. No. If they have no neurologic symptoms, why would you? Make sense? Why would you do a big spinal surgery for somebody who actually has no symptoms? You just happen to find some kind of defect on an x-ray. Make sense? Good? Same thing with, bless you. Same thing with radiculopathy, right? It's an important concept. With radiculopathy, are you going to treat every patient with radiculopathy with surgery? No, only when and if they progress to a certain extent. And you'll start to figure out what those right and left boundaries are when you get in practice. Okay? Are we okay with that answer? Okay. Just because we can doesn't mean we should. We think that's a motto in orthopedics. Just because we can doesn't mean we should. I tell patients all the time, I can make you different. Not you, but I'm pointing at you. But I can make you different, but can I make you better? That's what I think of, okay? Because God knows we got all kinds of surgical techniques, and a chance to cut is a chance to cure, okay? That's another thing in surgery, but that's more general surgery. But just because I can make you different, can I make you better? Okay? So operative high-grade slippage, 50%. You guys love that number 50%, right? Right? Because it fits neatly into a bunch of other stuff, okay? So we always say 50-50, 80-20. That's like if you're going to guess one of those, right? Right? Get smart. So neurologic findings, obviously, and they've done all the non-operative stuff, okay? Red flags, progression of slippage, you see it. You see it either on radiographs, serial radiographs over time, or they have neurologic symptoms, okay, again. So that is it in a nutshell, okay? Going back real quick, it kind of goes through ISMIC here. It doesn't really talk about degenerative. But again, ISMIC is going to be the more younger patients, okay? Football players, high school. And then degenerative, do you think that's going to be older dudes like me? Probably, right? So I think that's an area that we need to expand upon a little bit more. But the concept is just that. Everything else is the same. Make sense? So it's, yes, sir. You won't even let me finish. Yeah, go ahead. What you got? You do? Okay. I was going to say you should. Okay. So degenerative, so when we talk about degenerative spinal listhesis, right? I don't know why it's not on here. These slides get copy forwarded by the AC, and that would explain, here we go, degenerative, we skipped it, okay. That would explain why, when I was looking at it the other day, there's still errors in there as well. So, but when you talk about degenerative, everything else is the same, okay, but the cause, the etiology. So when we're talking about degenerative, right, you're talking about osteoarthritis, wear and tear over time, okay? What level does it commonly occur at? L4, L5. What was the common level for isthmic spondylolisthesis? L5. Okay, so get that in your mind. That's really the only thing else is different. Okay, even if you, I'm not telling you not to read these, okay? But I'm just telling you that that's really the only difference, okay? And if you disagree with me, let me know. But I'm just telling you everything else stays the same. Okay? Do you agree? Okay? Do you see the anterior slippage there? Okay? If you see posterior slippage, is that more significant? Yes, but that's not even part of your slide deck, right? It's not part of your book. They don't talk about that. Okay? So the difference is with degenerative spondylolisthesis, right? You're going to see degenerative changes. right? So it may not just be the pars interarticularis. It's not just a defect, they weren't just born this way, correct? Over time, the facets have also degenerated. The vertebral bodies have degenerated. Might they have a herniated disc as well? Absolutely 100%. Okay, so you can see a combination of things, okay? And then we already know this, right? MRI from neurologists. If you have abnormal reflexes, right, and you have abnormal sensation, then you're going to get an MRI, correct? You're going to get an MRI with contrast, with no history of prior spinal surgery. With no history of prior spinal surgery? No. You're just going to get an MRI, okay? Make sense? If they have a history of prior surgery, you're going to get it with contrast. If they cannot undergo an MRI for a number of reasons, the big one that I talk about is metallic routine bodies, right? Or certain implants, then you'll get a CT with biogram, okay? Good to go? You know, how many times do you think I've sent a patient to radiology to get an MRI, and then the radiologist does the sheet, right? The sheet that they give them, and they know they got these plates and stuff, and I'm like, that's fine for MRI. That'll be fine, right? We put those in all the time. Patients get MRIs, be fine. But the radiologist is like, nope. I need to know exactly what plate it was, exactly what material it was, et cetera, what the composition of that metal was, et cetera, et cetera. Where do you think that information is found? Find the operative report. Don't find the surgeon. They may be retired. Okay? Find the operative report. You are correct, sir. Sort of. So find the operative report. If it's Genesis, should you be able to look in there if the surgery was done in the military network? Yes. If they got their surgery done in the community, will you have to reach out to that healthcare system? Not you. You have to get your minions, right? Get your records people to go out there and find them, right? So they have to do all these releases. Patients have to release this whole thing, right? So again, MRIs can be delayed depending on if it's routine versus acute. Okay. All right, any questions about that? I apologize for skipping that. I got too excited. But that's really the only things that are different. So spinal listhesis, degenerative, is basically older people. Spinal listhesis, ismic, is younger people. Okay? Now, can this spinal listhesis, ismic, present in later on in life? Again, like I told you before. And therefore, is it degenerative then? They haven't lived that long. Right? But by definition, spinal listhesis ismic is younger patients. Okay? Make sense? Incidentally, why is it called ismic? Does everybody know? Do you guys know what an isthmus is? Do you have an isthmus in your thyroid gland? Is it something that connects two adjoining structures? Is that what your pars interarticularis does? Okay. So if you were born without that connection, is that ismic? Spinal listhesis? Yes. So that connection, you were born without it. Hopefully not being crude, but came out the chute like that. Okay? That's just how you were born. All right. Quick review, and then you're done. You're like, stop talking. But when it comes to the topics that we talked about, we give up. What questions do you guys have for me right now? We will do a test review. It will be whenever you tell me. We'll see, Arnold. Right? I will send you guys some questions and all that. But what questions do you have for me right now? All right, because we have a few minutes. I'll give you guys a few minutes if you want to ask questions. Otherwise, I'll stop talking. All right. Sir, what can I answer?
So I was reading this about osteoporosis.
You were. So you were the guy online. Yes,
You
sir.
said that secondary osteoporosis can be caused by steroid use, correct?
Yes.
On the interventions, it then says anabolic agents
Yes.
are used for it, so I was confused by that.
Yeah. So are used to treat it
Yeah, it's
or prevent it?
for intervention, which
Yes,
I understand
okay.
is treatment.
Perfect. So that's why I leave the treatment up to the pharmacology professor, right? Because then I won't confuse you, all right? Because do I treat osteoporosis? No. But do I know about it? Sure, right? So the difference is that steroids have different effects, right? All steroids are not created equally, we know this. For those people that know about, that have friends that go across the border at Tijuana to go to that Mexican pharmacy to get the stuff, right? There's good stuff and there's bad stuff, right? So there's different levels of effect, whether it's going to be at the actual muscle body level, right? So the fibers, okay? Or it's going to be on other areas, okay? So his question was, when you're talking about secondary osteoporosis, okay? So when you talk about primary osteoporosis, how many types are there? 2, right? What's the first one? Postmenopausal. Don't say hormonal, you'll make somebody angry. Right? Yeah, don't say that. Well, postmenopausal, and the second one is senile. Senile means old, crazy dude. Just old, seasoned person, right? So that's what they mean by that, okay? So then what's the whole other category? Secondary, yeah, secondary. So you can put lump secondary, for the purposes of my course at least, into think it's caused by something else, so by some external factors, okay? Some other disease process that's not hormonal and not old related, right? Senile, and that can be reversible potentially, but may require other treatment as well, okay? Did I kind of answer your question? Yeah, did, okay. You're just agreeing and then you'll ask me again later. No, and then, because there's more to it than that, I agree with you. But is it fair for me to talk to you about the treatment for it right now, since you don't know about bisphosphonates? You guys know about bisphosphonates? No? It doesn't make sense, right? And I'm not gonna test you on it, okay? Make sense? But here's the thing, I'll do a rolling contract with you guys. Whenever block we go forward into, then you get that knowledge, right? That level of knowledge that I tell you haven't gotten yet. And then you're like, now you want to get into it as a class, I'll do it. Okay? But right now you don't have the tools, you're not armed for the fight at hand. Make sense? So it's unfair to cloud your mind. Think about this for a second, okay, honestly. Right? Make eye contact, right? It's not fair for me to cloud your mind with a bunch of knowledge you don't understand. Because when you're taking this test, you're already stressed out enough, right? And you got all this stuff, and you're like, but he was talking about this, I don't know what the hell he was talking about, right? But I confused you, right? So I've learned to not do that. Make sense? Right? Do you think I want to get crazy with talking about surgery? Absolutely, 100%. But I know it's just going to serve to confuse, and that has nothing to do with your level of intelligence. It's just you don't have the knowledge. Does that make sense? Okay? Any other questions? I'll stop talking. Thank you.